All right. Yeah, I can join. So I'm not going to join with audio, Dr. Knapp, because.
So hello, everyone. I'm Ken Knapp. I'm the Director of the Center for Long-Term Care, and it's my pleasure to welcome you to today's webinar by Carol Levine, who is a true treasure. She's a real family caregiving expert, one of the country's top caregiving experts. I want to acknowledge some people who helped make today and our other events possible. Michael Frankfurter, Michael Cotter, and Juan Castro from Educational Media, who are always so helpful. Student research assistants and graduate assistants, Taylor Gerber and Ed Hassan. Our Center for Long-Term Care research scholars and advisory board members. Please visit our website. There's the link. It's pretty easy to remember, nymc.edu/ and it's Center for Long-Term Care with hyphens in between. And Cindy Jakubowski, the administrative assistant for the Department of Public Health, always goes above and beyond to help out. Dr. Mark Kittleson, who's the chair of the Department of Public Health, and Dean Robert Amler and Vice Dean Ben Johnson have always been so supportive. So thank you all for joining. Today's webinar is going to be recorded. So let's all make sure we mute ourselves unless we're talking. The recording and Ms. Levine's PowerPoint will be made available on our center website. And if you shoot me an email, I can also send you the link. If you have a question at the end of Ms. Levine's presentation, like during the presentation, you can just send me a chat. And at the Q&A session at the end, I'll either call upon you, or if it just seems easier, I'll just read your question aloud myself. So let me introduce Ms. Levine. Carol Levine's presentation today is on family caregivers in a pandemic and an aging society, from invisibility to public health priority. Carol is a senior fellow of United Hospital Fund, where she was there for years and years, former director of UHF's Family and Healthcare Project, which focuses on developing partnerships between healthcare professionals and family caregivers, especially during transitions in healthcare settings. Before joining UHF in 1996, Carol directed the Citizens Commission on AIDS in New York City from 1987 to 1991, and the Orphan Project, which she founded from 1991 to 1996. As a senior staff associate of the Hastings Center, she edited the Hastings Center report, and we're also very fortunate to have Ms. Levine as a member of our center's advisory board. So thank you so much, Carol, and I'm going to stop sharing my screen so you can share your PowerPoint.
Okay, thank you. Thank you, and it's great to be with you virtually and to share with you some of the things that are happening in the world of family caregiving as a result of the COVID pandemic, but that have been problems and issues for quite a long time. Next slide, please. UHF, United Hospital Fund, is an independent nonprofit organization that analyzes public policy and finds common ground among diverse stakeholders. It has been around since 1879, so it's quite an established organization. Next Step in Care is the website that we created in the Families and Family Caregiver Project, and I have to say, I think probably it needs some updating, and since I left the center at full time, it hasn't been updated, but the basic stuff is still good, and I would encourage you to take a look at it. Next slide. I'm going to try to cover a lot of material, but And so I might not get into everything in detail, but this is what we'll try to do. Family caregiving has not been seen as a public health or public policy issue, just something that families do, and it's up to families to figure it out. But today, in today's world, it's complex and challenging, and it has an impact on not only public health, but all kinds of other systems. Changing demographics, chronic illnesses, healthcare system changes are making family caregiving a public health priority, particularly in the era of COVID-19. I want to mention some of the regulations, federal regulations, state regulations that are intended to support patients and caregivers who present barriers and could benefit from some revisions. And there are lots of future needs for research for any of you who are interested in going forward at this: heterogeneous populations, expanded services, and supportive policies. Next slide. Well, when we think of public health, we think of all these important words: epidemiology and health disparities, prevention, research, disease prevention. We don't generally see, as in this word cloud, family caregiving. Maybe it's there in that little red bubble called social support, but it's not a major, has not been a major field in the area of public health. Next slide. Public health has evolved, as you probably know. The traditional mission was controlling communicable diseases, originated to control malaria, and that's why it's in headquarters are in Atlanta. And control of communicable diseases is still a high priority, as we know. Prevention was added in the title in 1992, and that includes a wide range of topics: healthy aging, behavioral health, chronic disease. So it has expanded, and in some ways, family caregiving kind of fits in, but not on its own. There's been obviously a lot of interest in population health, disparities in health access, and outcomes across defined populations, and COVID has made that more important. Social determinants of health, a recognition that population is health is affected by more than clinical care, includes housing, food, environment, and I would say family support. Why does caregiving belong in public health? Well, for the first reason, it affects millions of people, and I have a little slide of that later. It has an impact on the health and quality of life of both the person who needs assistance and the caregiver. And there's a negative impact on caregivers' mental and physical health, and that's been shown. It's actually worse now. And a negative impact on employment and financial status. And that has been, and I'm sure you've seen stories about how women in particular are affected by COVID, not becoming ill, but having to manage a job or losing a job and taking care of somebody who is ill, but also taking care of kids, homeschooling. So if there's all of those things that affect the family caregiver, there is a tendency to lead to greater reliance on public resources. Social determinants of health, which we mentioned, affect the ability to provide care and access resources. So all of this affects the need for community resources, affect healthcare costs. So there seems to be no doubt that caregiving has a role to play in public health discussions and policy. Next slide. Now, who is a family caregiver? And whoever you talk to may give you a slightly different definition. Sorry, that's my phone, I'm not answering it. Someone who provides or manages the care of a family member, friend, partner, or other person who has a disability or chronic or serious illness. Sorry.
I know. Call from. No. Phone. I know.
Oh, I hate this when the phone rings. All right, what family caregivers do? And the first thing that you will always see about family caregivers is that they manage ADLs and IADLs. ADLs are activities of daily living, personal care. IADLs are instrumental activities of daily living, household chores, shopping, those kinds of things. That seems to be, for many people, all they do. On the other hand, studies that I've been involved in and experience, which I'm sure all of you know, family caregivers provide what we're calling medical nursing tasks, wound care, managing multiple medications, managing mechanical equipment, all kinds of things that used to be only the province of a trained nurse. Now, well, you're the daughter, well, you can do it, it's not so hard, and that happens. Family caregivers coordinate the care plan among many providers, and that can be a challenge in itself. Managing finances and insurance benefits, also difficult. And they also do what families do best. They provide emotional support and companionship. And it's a long-term commitment. 70% of family caregivers spend between 2 and 10 years caregiving. In my own caregiving experience for my late husband, I was his caregiver for 17 years, and he was at home for those 17 years with a traumatic brain injury and quadriplegic. So I know firsthand how hard it is. Next slide. This is an infographic from the National Alliance on Caregiving AARP survey, which is Caregiving in the US 2020. And this survey is done every 5 years. So I think you will see all those arrows trending up. There are more caregivers. Everything is worse than it was in 2015. More caregivers are caring for more than one person. More of them are reporting difficulties, coordinating care, and having worse health. Almost half have had at least one financial impact. Now remember that this survey was released in April of 2020, but it was the survey was done before COVID. So this is kind of the baseline, and everything was getting worse then. I don't know what it would be like if we repeated the survey now. So this survey found that there were about 53 million people, adults, providing care. Every survey you see will have a different number because they start from a different perspective, and whether they include all adults, only adults over 65, adults and children. But the bottom line is there's somewhere around 45 million people who are family caregivers. Next slide, please. The impact of COVID-19. All of the above issues that caregivers have been experiencing, plus increased isolation and loneliness. And I've been on a number of calls lately with people discussing what is happening to caregivers. First two words they say are isolation and loneliness. They said that before, but now they mean it in a different way. They really are isolated. Now they're balancing work and homeschooling and caregiving, and without any help. They worry about bringing outside help into the home because they don't know if it's safe. And even if they had been working with someone, they're not sure whether it's safe to have that person come, and that person may not be wanting to come because you don't know. They're caring for an older person who may be at risk. The usual community support may be limited or closed. That's, adult daycare, senior centers, all of the kinds of things that people who are older and isolated can go to with some help getting to and from, but they're not as available. The person who is ill may be very confused about the changes in routine, who's coming, who's not coming, and especially with anyone who has cognitive difficulties, that's very upsetting. And the caregiver may not be able to respond in a way that satisfies them because they don't know the answer. Usual health care may be difficult to access, or there may be different methods. Telehealth has become the way of going to the doctor's office, and it's very effective in some situations, but it doesn't have the same full comprehensive exam as one that is person to person. And a lot of people have simply not followed up on things that they should have followed up because their regular doctor isn't available. And adding to that, of course, the financial worries. I always try to bring that in because it is really expensive and difficult. And people are sometimes reluctant to talk about money because it seems to take away from the love they feel for the other mother or whoever the person is. But it's a real fact. And there are significant financial worries that have an impact on the caregiver's own future. Next slide. I thought this was a very interesting report from CDC on mental health. It was a report that was issued in August. It included, for the first time in my knowledge, unpaid adult caregivers in a survey of mental health challenges. The other people who were in it were younger adults, essential workers, and racial and ethnic minorities, which would be more standard categories of people. Although, in my view, unpaid adult caregivers should be considered essential workers. But here they were separated out. And of the 5,000 survey respondents, 26.2% reported being an unpaid caregiver to an adult. Well, that's a pretty significant number. And compared to non-caregivers, the adverse effects that they reported, anxiety or depression, were more prevalent among caregivers. One or more adverse mental or behavioral symptom, 66.6% versus 31.8%. Increased substance use, considerable difference. And thoughts of suicide, 30.7% versus 3.6%. That's scary. I was really shocked. And yet, when news stories appeared on this report, none of them mentioned the unpaid adult caregivers. They talked about the essential workers and the racial ethnic minorities and gave those numbers, but not the unpaid adult caregivers. So I thought there's an opportunity here to build on this. Next slide, please. Family caregivers, I mentioned, are doing all the kinds of medical and nursing tasks that only trained nurses or therapists used to do. At United Hospital Fund, we worked with ARP, the Public Policy Institute, and did a survey called Home Alone, Family Caregivers Providing Complex Chronic Care. That was issued in 2012, a lot of press, and we redid it in 2019, and it was Home Alone Revisited. Nothing had improved. Most family caregivers have little or no help at home. Nearly half of all family caregivers were doing complex medical nursing tasks, medications, wound care, special diet, but they don't get adequate training in hospitals, doctor's offices, or emergency departments. And employed caregivers with people with cognitive or behavioral problems did medical nursing tasks at the same rate as non-employed. So it's not just, the people who are home all day, it's people who are working, and maybe now they're home all day, but they are doing all of those complicated tasks, and they worry about it. They worry about making a mistake. They're worried that they're not doing something right. And the person they're taking care of isn't so sure that they're not making a mistake. And, do I really have to take this medicine again? There's a kind of insecurity when you're the patient, and you know that this person who's doing all this stuff has never done it before. So they want additional training, but they often can't get it. It's very hard to get outside of a healthcare setting, and it's very hard to get at home unless you have home health care, which even then is not always adequate for this. Next slide. So there are lots of studies that are on the physical and mental health impact. They're limited time and population, and as I said, they use outdated definitions of caregiver, just ADLs and IADLs. Caregivers generally rate their health worse, and we've seen that in the other slides. Diminished immune response, that's important now. It's getting flu shots, leading to infections, less protection from vaccines, assuming we have a COVID vaccine. Double the risk of heart disease, diabetes, and arthritis, and lower levels of self-care. And then the one study had 40 to 70% have clinically significant symptoms of depression. And caregivers, not surprisingly, caregivers of people with dementia are particularly stressed. So women are at higher risk than male caregivers. There are more women providing care, but there are also lots of men who are doing it. But they are often able to gather more help than women. Next slide. So the challenges for family caregivers, the system is hard to navigate. Sometimes I show a slide of a maze where it's complicated, but you can see if you follow the path, you can get to the end, compared to a Jackson Pollock painting where there's no rhyme or reason to it, and there's no way. That's what caregivers see, the Jackson Pollock painting. It can navigate a maze, but not chaos. The financial stress, which I've mentioned, cost of medications, out-of-pocket costs, family conflicts over who, what, where, providing and paying for care, and disagreements with the care recipient. Safety versus autonomy. This calls on my ethics background. What's more important? Having the person feel that they are making decisions for themselves, or taking away the car key. Where they may resist care, they may resist medication, and they may resist, even if it's available, having help at home. And of course, the loss of wages, Social Security benefits, and retirement income. I think there's another column there. Ed, there another column? Yep. There's an ambiguous role for caregivers. There's no scope of practice. Family caregivers do what needs to be done. They're often called informal caregivers because they aren't paid. I don't like the term informal, and I don't see it as much now because it suggests something that's not really rigorous, it's not really important, it's informal, and that's not the case. Sometimes they're called volunteers, but the surveys in the Home Alone surveys, a lot of caregivers said they had no choice. They were the only ones who were at all able to do it or willing to do it, and they had to do it. They're not routinely included in transition planning, but the care plan is unrealistic without the family caregiver needs and abilities assessment, and those assessments are not often done. There are few incentives for providers to address caregiver needs without dedicated revenue streams for assessment and caregiver services. So we're kind of stuck where caregivers need a lot more information, practice, support to learn how to do this job, and it is a job, And there's very little incentive for a busy, overstressed provider to address those needs. Slide. This is an impact on the economy, and most family caregivers have worked at a paying job, at least 3/4 of them, and almost 70% report making work accommodations, including arriving late, leaving early, stopping work entirely. And businesses lose an estimated 25.2 billion per year in lost productivity. And there's a link between elder care and higher employee healthcare costs. So in the pandemic, women and older workers, e.g. caregivers, are least likely to be rehired. I know that a lot of effort is being put into assisting employers in taking advantage of the supports that do exist and the laws that do exist, especially in New York State. But it doesn't seem to reach everyone who needs it most. Mostly it's very big employers with with human resources and all sorts of possibilities for support. It's not the low paid worker who's working in a diner, or even maybe the low paid aide or housekeeper in the hospital. So there's a lot of work to be done on that score. Next slide, please. And here's just some statistics about aging. 2030, older people will outnumber children. The ratio of potential caregivers to older adults is dropping, 7.2 to 1 in 2010, and down to 4 to 1 in 2030, and 3 to 1 in 2050. There's long-term chronic illnesses dramatically increases the need for caregiving, as well as the survival of younger population with disabilities. And Alzheimer's and other dementias among the older population has certainly had an impact on the number of caregivers required. And again, the pandemic has brought new emphasis on the contribution of caregivers, because more people are needing the kind of help that is no longer available, even say in assisted living or in nursing homes. Until things get settled out, it's very hard to find the additional support that's needed. Next slide. The healthcare system, as you all know, is changing, and it has changed, and now there are effects on caregiving. There are shorter hospital stays with many post-acute care needs, whether in a skilled nursing facility or at home. Hospital stays are short. And if you're the president, I guess it's only 3 days. But emphasis on controlling hospital costs leads to more home-based, i.e. family care. And there is a big emphasis now on hospital at home. And that means setting up a home situation that basically has all the necessary equipment that is in a hospital, not an ICU, but a regular room. And a lot of people like this, and even a lot of caregivers like this, because they hate being in the hospital because it's so difficult. But it does rely, the family is providing the cleaning, the meals, all of the daily care that is provided in a hospital by staff. So it's not a total win-win for the family. The elder care workforce is declining. That's the people who are doing home health care or in assisted living or nursing homes, instead of increasing. So telehealth, which I mentioned, is increasing, and other technologies, but many older adults are just not either willing to try it or able to manage some of these technologies, and require a family caregiver to help them. They will do it if somebody is standing there, helping out with each step. but it's not necessarily something that's easy for them to do alone. Slide. There have been a number of articles and reports linking caregiving to public health. And the 2007 article by Rhonda Talley and John Cruz, who were both then at CDC, I know Rhonda's not, I don't know about John, was a first sustained look at conceptualizing caregiving as an emerging public health issue, 2007. And they wrote, there's considerable overlap in the individual needs of caregivers, foundation of an enormous system of care, and the public health needs of many communities and their members. The better their health, the more likely caregivers are to sustain their caregiving roles. That article really set the stage for a lot more. Next slide. This was followed by a Family Caregiver Alliance report on California's caregivers. No similar report that I know of from New York State. One from India, which I thought was really interesting. We cannot leave the responsibility of home-based care to families and hope that the traditional family network is capable of absorbing any amount of stress. I salute the Indians for saying that straight out. And then there was a National Alliance on Caregiving, also had insight to advocacy and addressing family caregiver as a national public health issue. So there is support out there for building up the public health role and visibility in family caregiving. Right? There's limited surveillance right now. The Burfus survey, this is surveillance, a key public health responsibility, and it's conducted annually, and it's it's a big survey. The core questions are asked in all the states are questions about diet, physical activity, healthcare access, health conditions, and optional modules are offered to states. Next slide. Okay. The Burfus has a caregiver module. The screening questions were included in the Burfus core in 2009, and thereafter was included in an optional module. From 2015 to 2018, 44 states, Puerto Rico, District of Columbia, participated at least once. In 2017 and 18, both New York and New Jersey participated. I think they've been fairly consistent. Caregivers reported on the intensity and duration of caregiving. Those who are not a caregiver were asked if they anticipate becoming a caregiver in the next 2 years. National and state infographics are on the CDC website. They're not comparable because the same states didn't use this module in each period. And it's hard to make this actionable. Next slide. This is the New York infographic, 2017 Behavioral Risk Factor Surveillance System. 1 in 5 adults are caregivers. And they, over half have provided care for at least 2 years, and a fourth have provided care for at least 20 hours a week. Quite a lot. 60% of the caregivers are women. 19% of the caregivers are 65 years or older, and 38% are caring for a parent or parent-in-law, and 10% of caregivers are providing care to someone with dementia. The asking how do they help, 80% manage household tasks, that's the IADL stuff. Over 50% assist with personal. Future caregivers, 1 in 5 think that they'll become a caregiver within 2 years. So this is New York State and how New York State looks. And it's similar to the national infographic, a little different, but not really. Thank you. Next slide. Okay, here's some basic data. What's missing? They don't ask anything about the complex kind of care involving many medications, wound care, operating medical equipment. It's just ADLs and IADLs. There's no question about care coordination or navigating the healthcare system. There is a question about choosing one unmet need from a list, including respite care, classes about giving care, support groups, individual counseling. Except for the classes about giving care, all of those options suggest that the problem lies with the caregiver's emotional needs, not with the availability of healthcare system support or public health resources. No. Well, why don't you talk to a counselor, dear? You'll feel better about it. I heard this all the time. Didn't feel better about it. Next slide. Now I want to go to some regulatory issues. The ambiguous policies lead healthcare professionals to avoid risk of non-compliance and privacy protection under HIPAA. That's come up in the president's doctor's reports on his health. I think inaccurately representing HIPAA. And I can say why later, maybe. The impact on caregivers are often neglected. So the rhetoric about value of family caregivers, and we hear that all the time, is not matched by actions. And even policies that are designed to support family caregivers may have barriers. Next slide. The CARE Act, Caregiver Advise, Record, and Enable Act, was a response to the Home Alone study. AARP said, what can we do to make this better? And they pushed very hard to get the CARE Act passed in states and territories. Now the law in 43 states, territories, and provisions vary. So they're not all the same wording. The New York State law went into effect in April 2016. So it's been around now for quite a while. It was intended to ensure that family caregivers are identified in hospitals and trained to provide post-discharge care. So far, it only applies to hospitals, although it really should apply to skilled nursing facilities and rehab centers and any other place where there is going to be a transition to another setting where the level of care is significant. The 4 basic requirements: offer the patient an opportunity to identify a caregiver, document the person's contact information, obtain the patient's written consent in New York to share medical information with the caregiver, inform the caregiver about the expected discharge date, and provide instruction about care at home to the caregiver. Next slide. So I think the desire of the CARE Act, the intention of the CARE Act is really important. But to date, as far as I have been able to ascertain, much of the implementation has been about retooling the electronic health records to include caregiver information and set up staff processes. There's a tension between patient autonomy and caregiver need for information. The patient must name the caregiver and may not want to do so for many reasons, including, I don't want to burden my wife, my daughter, my partner, and that will stop the process. There's no indication of when the new notification of discharge must be given, and really important, there's no compliance. There's nothing that says we're going to check up on you and see, make sure you're doing this. Now, I will say AARP, they were behind this CARE Act, and they have done a lot of visiting and interviews across the country to see what different states are doing in terms of implementing the CARE Act. And I believe that within the next few months, there'll be some reports issued on what will probably be called best practices, but will probably also include, I would expect, some indication of some of the difficulties that have been encountered. Right? And HIPAA, again, the federal privacy rules do not prevent clinicians from talking to patients' families and friends who are involved in care or pay for care, as long as the patient does not object, and the patient may object. HIPAA does not require written consent, but some of the state Care Act laws, including New York, do, and some hospitals do too. You hear a lot about crackdown on breaches of privacy. They focus on the security of patient data. You know, somebody takes a laptop home and leaves it on the train or something like that, not clinicians talking to families. So HIPAA has been used as a way to avoid difficult conversations with families. And HIPAA won't let me talk to you. That's not really true. And a lot of caregivers are not well informed about HIPAA. Next slide. Referrals to post-acute care are a really important and complicated subject. We did a study at United Hospital Fund, and it was called Difficult Decisions. And there are 4 reports online. The illusion of choice is the one that I and one of my colleagues describes interviews with patients and caregivers about the process of choosing the skilled nursing facility for rehab, short-term. This is not going to a nursing home. This is short-term rehab. Of course, this was before COVID. So this was what we were encountering then. And what we encountered when hospital staff often give patients and caregivers a list of SNFs in the area, but do not help them make the choice to avoid steering, which is prohibited. Steering to a place that the hospital has a financial relationship. Caregivers are told to visit facilities, but without enough time to canvass all the options. And now, they aren't allowed to visit the facilities. You can do a virtual tour, but that doesn't tell you what it's like, what it smells like, what it looks like. So it's very difficult to make such a choice. The people we interviewed said location was the most relevant in choice, but other information was lacking. Some people lucked out. Some people did a lot of research and still didn't like where they went. So it was very hard for them to make a good choice. Spousal impoverishment is another issue that vulnerable caregivers experience. So federal Medicaid rules allow spouses whose partner is in the nursing home to retain certain assets and income. Under the ACA, this also applied to spouses whose partner was at home. And this provision ended. A temporary extension was passed in 2019 and later extended through 2024, but there's no permanent extension. So if it's not extended permanently, it penalizes spouses who keep the person at home rather than in a more expensive Medicaid funded nursing home. New York State has rules, but it's not clear if the federal rules are not extended. This is one of those endless policy discussions that seem to get put off, and nobody wants to make a real decision. Next slide. Here are some tools that if you are in a situation where you are a caregiver or are talking to a caregiver that you can use. Most caregiver assessment tools focus on long-term burden, and that's a word that caregivers don't like. They don't like to think of mom as a burden. They don't like to think of what they're doing as a burden. But this is the Zaret burden interview. And our next step in care, there's a short 3-part tool for community or hospital providers that focus on immediate needs, availability. Are you there? Can you do this? What training do you need? And really, really important, what worries do you have? When we tested this in hospitals and asked usually it was a social worker or a nurse, what did they say? Well, the answers were anything from, I'm worried about getting home so that I can pick up my kid from school, to I'm worried about my mother, is she dying and I don't know it? Or I'm worried about why God has done this to me. I mean, there were range, but gave the caregiver a sense of someone is listening to me. So it was really important. They're all available online and at least worth looking at. I don't think there's any changes we might make in that. Next slide. We're getting to the end. There are community supports. There are some that are directly focused on the caregiver. I know some of the ones in New York City, and I know Westchester has a summit as well. And then there's some that are focused on the patient and indirectly help the caregiver, like care coordination and long-term support services, home health care, adult daycare, and home delivered meals. But these are often under threat, consistent cuts to human service budgets at municipal, state, and federal levels. They aren't given a high priority. Next slide. So looking ahead, public health agencies, these are some recommendations, to develop enhanced surveillance tools so that all types of caregivers are included, with a special emphasis on minority groups and ethnic groups, because they often have the fewest resources and are the most involved in long-term care. Longitudinal research within an epidemiologic framework is needed. Hospitals should develop robust training on HIPAA, the CARE Act, and post-acute care referrals, as well as, just training people on how to do an injection. When my husband was in the hospital, I don't know whether it was risk avoidance or what, but no one would allow me to do anything that touched him. It was only a nurse could do anything. I was expected to watch, and by watching, be able to do. It didn't work that way. So assessment of family caregivers should be standard practice. Look at me, I can't do this. When we need some new assessment models that capture the reality, invest in programs that support caregivers. There are lots of good ones out there. Payment incentives for providers, and increase funding for the National Family Caregiver Support Program and other programs that are in the federal and state funding plans. Next slide. So public health needs the family caregiver. And as you see the family caregiver, that little white tile, you take that little white tile out and the whole thing falls down. And that's what I see as the absolute necessity to bring family caregiving into the public health realm and make family caregivers partners. Next slide, I think it's the last. Yes. Any questions? And I will turn it back to Ken.
Thank you. That was awesome. And so we do have several questions, and we'll start with Dr. Imran Ali.
Yeah, I just want to say that was a very comprehensive overlook about the challenges for caregivers. I just finished my geriatric fellowship. I'm doing a fellowship in palliative care now, but it was very hard for my patients who had cognitive impairment, and the caregivers, I cannot tell you, since the daycare centers had closed down, the caregivers were faced with not knowing how to handle their spouses who were agitated, who were delirious, who, when you disrupt a person with cognitive impairment, their routine, I mean, it can be all haywire. I remember just on the phone trying to help this desperate old lady who was talking about her husband. I think she called me 8 times in one night when I was on call, because her husband was thinking that he was in a train station and he had to go to catch the train. And she had to try to distract him. I mean, there's only so much medication I could give him. So I had to, play the part of a conductor on a train on the phone and tell him that the train was canceled because of a snowstorm. It was a very difficult time to redirect the patient.
Yeah.
And it was just only one story. And if you can just see how many calls during this COVID time, most of my cognitively impaired patients, their dementia just accelerated rapidly. And I
Really?
even had some patients in the nursing home who didn't have visitors attempt to commit suicide. So it was a devastating couple of months. I mean, I absolutely, it's just, I mean, caregiving is a full-time job, and this pandemic has really affected lots of families out there.
Yeah. Oh, I feel for that family person and for you trying to restore some semblance of sanity there. I hear stories like this, and it seemed, my only thought was that if the caregiver, the normal routine can't be reestablished, but a new routine can be. And this is now what we do. So everything should be, you know, this, we get up, we get dressed, we get breakfast, we do this, we watch this, so that there is some semblance of, it's some semblance of security that I tell you, I'm doing it for myself. Because if I don't do it, I lose the day, and I can get very cross. So, but I totally understand, and I think that has not been understood by all the people who are, you know, making great pronouncements about.
Right now, just one more thing, though. I mean, from a public health standpoint, I mean, I want to do my thesis on how long-term care can improve pandemic preparedness, disaster preparedness. And I understand the visitor restrictions. This is very important. But I think there should have been some provision to make exceptions for some of the very, very delirious patients if they could have a loved one who could be COVID tested.
Yeah.
I don't know, or if they could live with their loved one. I mean, because there were just so many people I sent to the emergency department for, you know, agitation. I mean, it was just, they just completely broke down without their loved one able to be there. And even now, in my palliative care rotation, we have a hospice, and we can't have the patient's families come in unless they're imminently dying.
Yeah.
So it's so hard to predict that. And I've had many people waiting for their COVID test to come back before they can actually make it in to see their loved one before they die. So, I mean, it's just such a challenge.
I know one group is trying to put together what some hospitals are doing. One of them that I remember has a special communications person who is in charge of talking to the families, giving them good information, listening to them. And so even though they can't be right in the same room, they feel as though someone is really looking out for the person and they're getting the information. It's a substitute, but at least it seems to take away some of that immediate anxiety. I think other places have said, well, the whole family can't come in, pick one person. And that may
there's a lot of lessons that we will learn from a health standpoint, and especially with long-term care and infection control, which has been a problem in long-term care since forever. I mean, just C. diff and pneumonia and MRSA and whatnot. So this is a very good presentation. I really thank you for bringing
Well,
that.
thank you for your question, and good luck.
So we have, so it's getting close to 7. Is it okay if we spill over a little bit?
Sure.
Awesome. So Ashlyn Morse has a question about Medicaid funding for family caregivers.
What is the question?
You have to unmute yourself.
I apologize, I was on mute. Hi, Carol Levine. It's a pleasure to meet you, albeit virtually. Thank you so much for that lovely presentation. So I was just wondering, I've heard a lot about family caregivers and just very little about Medicaid funding, potentially to provide some sort of income relief for family caregivers. And I was just wondering if maybe you could expand upon maybe some of the funding sources that are available for family caregivers, and maybe some of the additional resources if they offer anything like childcare, mental health services, or any type of even medical insurance through these programs.
Well, one thing is available, which is that certain family members can be paid to provide the care at home.
Mhm.
If the person is on Medicaid, only the only exception is if you are a spouse, because that, you promised all those years ago you're going to do this for me. Or if you have legal guardianship, in which case you are committed to it. But an adult child, a sister, anyone else or friend can be hired. Now you're not going to make a lot of money, but it is for people where the tasks are not particularly onerous or particularly complicated. You wouldn't want to just say, oh yeah, this is the dialysis machine, turn it on at 3 o'clock. No, it's more being there and managing all of that. There in New York, there's Medicaid managed care. So a lot of what is available depends on which company is managing that. They can have caregiver support services, and then caregiver support services are available through the city. This is what I know, the City Department of the Aging, and they're at the 311 call, and they say, I'm a caregiver, I need help, and they have trained operators to direct you to something that would be helpful. There's very little financial support available that I know of. It's really the only thing, and that's only for Medicaid, so it's not for people who are on Medicare. Part of the Medicare Advantage, incentives in the last round was providing some special supports for caregivers if your person was in the Medicare Advantage. But I don't know how that worked out. I would be a little leery of it, but it's possibly very good. So you've raised a good question, but right now it's it's really, really hard. Really hard.
Thank you very much.
You're welcome.
JIR, do you have a question about federal funding and caregivers who might be muted?
I didn't get that.
Oh, hello, Ms. Levine. Thank you so much for a lovely presentation. I have a question that's, do federal government or state government provide any aid or any sort of help to family caregivers, especially to those who are unemployed or working low-paying jobs in this pandemic? And if the government is providing such help, is there any qualification process they have to go through?
I don't know of anything. You mean someone is a caregiver and wants a job? I'm not sure I get the. Tell me a story.
Okay, so family caregiver is unemployed and caring for old loved ones, or they are doing working low-paying jobs. They don't have enough financial support. So, is there any sort of help from the government?
Well, not beyond unemployment insurance. I don't know of anything that would be specific for caregivers. That whole area of financial support is really understudied and underfunded. Now, in other countries, I will say, like Germany, there is support, and there, first of all, there is a national health service, so families are not required to have all these out-of-pocket payments. But there is also some additional support and more help at home than we usually have. So it can be done. It's not that there aren't examples of how to do it. It's that nobody wants to pay for it. So I don't know of anything else, though. I would hope maybe there will be.
Thank you so much, Mr.
Sure.
Thank you. Chandra Pauline Daniel has a question about elderly population in correctional facilities.
Thank you, Ms. Levine. That was a great presentation. I liked your last slide with the picture that said public health needs the family caregiver. The point for me is I've been visiting prisons and taking a look at the scenario of the incarcerated population. But here the caregiver is completely taken out of the equation. Now the caregiver becomes the person in charge, the law enforcement officials. So my question is, are there any data around that? And is there any training provided to prevent burnout? Because one of my health econ assignments took me back into my, went to the, kind of interviewing officials at the Department of Correction during COVID. And I found out that law enforcement officials were, infected with COVID, and the caregivers as well. Now, is there, I noticed that there's a lot of data around hospitalized patients and those in long-term care facilities, but the incarcerated population.
Yeah. I've been working with AARP, and we have and other places together called Home Alone Alliance, and we've created a series of videos on how to do common medical tasks. Like most recent ones include peritoneal dialysis and hemodialysis and oxygen and all that. My job is to, to comment on the videos, but also I write resource guides that people can read, and they are in 4 languages, I think. So that's useful. The Red Cross used to provide really extensive training on all of those techniques, but as far as I know, they don't do it anymore. It's really a conundrum. It's such a need, and everyone seems to think somebody else should do it, but nobody does it. And even the home care people do try, but they're there and they're gone, and they're not there the next time you try to do it. You can't remember. So that's what these videos are supposed to help. But honestly, even with a video and a resource guide, I look at them, I say, I wouldn't be able to manage a PIC line. Are you kidding? No. I don't know if I've answered your question, but that's.
Thank you. So we have time, I think, for 2 more questions. And so first to Nicole Richardson, and then Al-Jawara Al-Sabah. So first, Nicole Richardson, you have a question about the mental health population.
Thank you so much for your presentation. It was really informative. And I just wanted to put out there first, before I ask my question, that I realized that there's a technological caveat here, because of the fact that, I was thinking about how we're even on Zoom right now, talking to one another, and that's such a barrier when it comes to especially senior citizens, or just, people that don't have access to technology in general. But if you think about cost savings and low cost alternatives, and I'm talking about just hooking up a simple HDMI cable to a TV so that it looks like an actual person is in a room, how you can correlate that with the National Alliance on Mental Illness, and whether or not they actually have looked into any programs about peer support. A lot of people are sitting at home right now jobless, and I'm wondering if this is, good way to incentivize people to get certifications or qualified in offering peer support to those in their community who've had similar life experiences. Simply because maybe families would be more likely to listen to them or to want to listen to them. And it's also a way to streamline information. So I guess my question to you is whether or not there's anything currently in place that looks at qualifying peer supporters to kind of act as the quarterback or the role that a primary care provider might provide in a pre-COVID world.
Well, there are navigator programs, and some in hospitals and some through the state, I think. This whole idea of peer support is one that I actually was talking to two people about last week, and it is feasible and it is important. Now, the closest thing that I can think of is community health workers who do go in, who know the communities, know the people, know what they need, are trusted, because that's a big part of it, is being trusted. But I don't know of any big or even, viable service that now exists. It's more catch as catch can, but I think it's a great idea and should be followed. Thank you.
Sure.
Thank you. Last question from Al-Jahara Al-Sabah.
Yes. Thank you again, Ms. Levine, for your amazing presentation. You opened my eyes to a lot of things that I had no idea about. So again, as reiterated by my fellow classmates, thank you so much for your time and your presentation. What I wanted to ask was, it's not really a question, it's more of maybe well, I guess it's a question. If you don't mind, because I was reading about this once I got the flyer to your presentation, and I read something about the Protecting Family Caregivers from Discrimination Act of 2020. I was hoping you can maybe elaborate on that.
Is that a state law?
I think that was, yeah, I think it was by Cory Booker in New Jersey. But
Okay.
I just find it interesting because reading about this, I think it gives, family caregivers much more options. I don't know if you'll be interested, like if maybe.
Yeah, I will say right off, I don't know it, and but I'd like to find out about it. So maybe you could send me more information.
Oh, I'd love to, of course.
And I'll look into, because I don't know. I'm trying to think if, the Family Medical Leave Act does prevent, does say that you can't be discriminated, like lose your job because you use it. And there is a New York State law that gives you certain time off and 80% pay or something like that. And that would have a non-discrimination. But those are all, the non-discrimination part is always kind of the add-on, like, and you will give you this and you can't be discriminated against. It's not a straightforward anti-discrimination law, but I'd like to know more about it, and it may be a good model.
Thank you for that. Before I ask Dr. Mark Kittleson for some final words, I want to quote Rosalind Carter, who said there are only four types of people: those who have been caregivers, those who are, those who will be, and those who need a caregiver or will need. So I'm sure I didn't do that exactly right, but Ms. Levine, thank you. As always, just terrific. Really appreciate it. Dr. Kittleson, some final thoughts.
Hey, yeah, again, Carol, thank you very much for doing this. This was great. I'm glad we recorded it, Ken, because there was so much information, and hopefully, would we be able to get the slides? Would that be possible as well, Carol?
Oh, yeah, yeah.
That'd be great. So I just want to, of course, my puppy has been quiet all night long until I start talking. But I just want to thank Dr. Knapp for doing this. this is really a great service. I know a lot of the students here. Really, I'm glad you're taking advantage of this because this is a really great, and Ken, good job with doing this. I mean, I think we could have Carol talk every week, and it would always be a creative idea. So thank you again very much, Carol. I'm glad that you were able to do this. I think last time you ended up taking a car and got stuck in traffic, so it was a little easier, I think, this time. So thanks again.
Yeah, I enjoyed it and I'm very happy. And it's good to know that, you know, reaching young people is really important because they're the ones who are going to have to carry some of this forward.
Thank you very much. Thank you, everyone. Everyone have a good night. Thank you.
And the VP debate is on in about 2 hours, so it'll be an interesting experience. So,
Oh, that reminds me. I've got to run to Bottle King.
yeah, make sure you watch it. It's really critical. All of you folks, you need to vote.
Yes.
W. Bush, wonderful guy. Okay, he came in with the idea of no child left behind. Who could argue with that concept? Great idea, but it got so convoluted that it'll take another generation to undo all those things that have happened. So the election is critical for the future professionally. So you really need to get out and vote. You need to get everyone you know out to vote, okay? So I can't tell you who to vote for, but you need to vote. That's what's critical. So.
Well, I already did, so great. Thank you, everyone. Good night. Thank you, Dr. Kittle. Thank you, Carol Levine.
Thank you.